Welcome to the Deep Dive, the show where we give you the foundational knowledge you need without all the filler. Today, we are taking the ultimate shortcut into cardiology. We're diving deep into the engine room, the foundational mechanics of the cardiovascular system.
And this is a really critical deep dive. We're working from a major pharmacology text, and our mission here isn't just to, memorize diagrams. It's to really master the normal operation of the electrical, mechanical, and pressure systems.
Think of it as an operating manual.
Exactly. If you understand how the heart should work, its balance of pressure, its conductivity, you instantly unlock how every single cardiovascular drug is supposed to fix things when they go wrong.
Okay, let's unpack this then. We're building a detailed map. We'll cover the heart's architecture, its own self-generating electrical grid, how the muscle actually contracts, how it manages its own blood supply, and maybe most importantly, the big hormonal systems like RAA that dictate blood pressure and fluid levels for the whole body.
Let's start with the structure. The heart is this powerful, hollow, muscular organ. And you should really think of it as two distinct pumps, sort of joined at the hip by a septum.
Right, the four chambers. So on top, you have the atria, the entryways. They receive the blood coming in. Right atrium gets the deoxygenated blood from the body. Left atrium gets the oxygenated blood from the lungs.
And below those are the ventricles. They're the main power pumps that push the blood out.
Okay, so the right ventricle sends the blood to the lungs.
Through the pulmonic valve. Then the left ventricle, well, that's the real powerhouse. It takes that fresh oxygenated blood and just shoots it out through the aortic valve.
Into the whole system.
The entire systemic circulation. And the key thing here, the insight, is that the flow is strictly one way. It's all dictated by those incredible tightly closing valves.
And that flow creates the rhythm we call the cardiac cycle, which is really just a period of relaxation followed by contraction.
Right. Diastole is the resting phase. The heart muscle relaxes. The chambers fill with blood.
And systole is the squeeze, the contraction phase. That's where the ventricles forcibly eject that blood, and the valves snap shut so nothing splashes backward.
And that contraction, it's governed by this really remarkable principle. Starling's law of the heart.
The rubber band analogy, but it's more than that, isn't it? It's like the heart's own immediate local compensation system.
Precisely. It means the more blood volume that comes back to the ventricles during diastole, stretching out those muscle fibers, the stronger and harder the next systolic contraction will be, up to a certain point, of course.
So the heart just knows. It knows exactly how much blood came in, and it pumps exactly that much out.
Yes. And that's why drugs that mess with volume, like your diuretics, have such a profound and immediate effect on the heart's workload.
The amazing thing, though, is that the heart is entirely self-sufficient. It doesn't need external orders from the brain. It runs on automaticity.
It's its own power plant. The whole system is commanded by the sinoatrial node, the SA node.
Yeah.
It sits right at the top of the right atrium. That's the heart's normal pacemaker. It sets what we call the sinus rhythm.
So the impulse fires, it travels through the atria, makes them contract, and then it hits this crucial speed bump, the atrioventricular node, the AV node.
But wait a minute. If the whole goal is efficiency, why would the body build a delay into its own electrical system? Why not just pump right away?
Oh, that delay is it's brilliant engineering. It's intentional. It allows a tiny fraction of a second for the ventricles to fill up completely before they get the signal to contract.
Oh, okay. So without that delay, you'd lose a lot of your pumping volume.
You'd lose significant stroke volume. So once it's released from the AV node, the impulse just races down the bundle of His through the branches and then into the superfast Purkinje fibers. That ensures the entire mass of the ventricles contracts all at once, simultaneously. And the electricity itself, the action potential, it's all about ions moving around. We don't need all 5 phases, but we have to know the key players. It kicks off with sodium rushing in to trigger the impulse. That's depolarization.
Right. And then potassium moves out to reset the cell for repolarization. But the critical link, the thing that connects the electrical signal to the mechanical squeeze, is calcium.
Calcium.
Calcium slowly enters the cell during what's called the plateau phase, and it's that slow trickle of calcium that actually triggers the muscle to contract.
Yeah.
This is why calcium channel blockers are so vital in cardiology. They directly interfere with that electrical to mechanical link.
And once a cell fires, there's an absolute refractory period. It's basically a safety window, right? The heart cannot be stimulated again, which prevents total chaos.
Exactly. It prevents fatal firing. Now, the heart is automatic, but the nervous system, it's like the volume control. The parasympathetic system, mostly the vagus nerve, that's what's dominant when you're at rest. It slows the rate down, keeps us at that nice resting 70 to 80 beats per minute.
And the sympathetic system is the accelerator. Stress, exercise. It speeds up the rate, quickens conduction, and really ramps up the contraction strength.
Let's talk about those mechanics. How does that calcium trigger actually turn into a physical squeeze?
Right, the heart muscle is built from these tiny functional units, sarcomeres. They're like little repeating engines.
Correct. And the muscle is just sitting there at rest until that electrical signal comes along, bringing calcium with it. The calcium is the key. It unlocks the binding sites on the muscle filaments, allowing them to hook together and slide past each other.
Which shortens the whole sarcomere. And that's the contraction.
That's the contraction. And that whole process requires a serious amount of oxygen and energy. And this brings us right back to Starling's law. But from a mechanical view, a stronger initial stretch lines up those filaments better.
Which leads to a more powerful squeeze. But there's a limit. You overstretch it like an old rubber band, and the contraction just gets weaker.
Exactly. Now, how do we measure this system? We use the electrocardiogram, the ECG. And here is probably the single most important safety concept the source material emphasizes. The ECG measures electrical activity only.
It tells you nothing about the mechanical function.
Zero information. A patient can have a perfect-looking electrical rhythm and still not be pumping any blood. You must always, always check their pulse and their perfusion.
So crucial. But the ECG does tell the electrical story. That little upward nudge is the P wave. Atrial depolarization, it happens right before the atria contract.
Then you get the big electrical thunderclap, that massive QRS complex. That's the ventricular depolarization. It happens right before that powerful ventricular squeeze. And the T wave is just the ventricles resetting or repolarizing.
Okay, so a disruption in that smooth rhythm. That's an arrhythmia.
Right. And they only really matter clinically if they interfere with that essential blood flow, with the cardiac output.
So if the rate is too fast, tachycardia, over 100, the heart might not have enough time to fill up between beats, and cardiac output drops.
And when problems start above the ventricles, like an atrial fibrillation or AFib, you get these chaotic, fast, irregular ventricular impulses. It leads to a really inefficient pump.
But the truly scary signals, the ominous ones, they start in the ventricles.
Oh, absolutely. We focus on those because they often lead to a total circulatory collapse, like ventricular fibrillation. On the monitor, it's just this distorted, irregular wave pattern. It means the electrical stimulation is completely uncoordinated. The heart is just quivering. It's not pumping any blood at all. Total loss of cardiac output.
Okay, we've talked about the heart pumping blood to the body, but what about the heart muscle itself? How does it get its oxygen? That's the coronary circulation.
Yeah, and this is a key differentiator. The coronary arteries, which feed the heart muscle, they get their blood during diastole.
During the resting phase.
Right. When the heart contracts, during systole, the sheer pressure and the position of the valve leaflets actually compress those arteries. They get squished.
Wow. So if the heart is racing, say at 150 beats per minute, the time it spends in diastole shrinks dramatically, which means tachycardia is dangerous because it's literally starving the heart muscle of its own oxygen supply.
Precisely. The filling pressure for these arteries is heavily influenced by your diastolic BP, which is why we track pulse pressure systolic minus diastolic to get a sense of that overall circulatory drive.
Okay, zooming out now to the whole system. The systemic circulation, we have two main parts. The arteries, arterioles, are the resistance system.
Muscular walls. They are the primary regulators of your blood pressure. They constrict or dilate.
And then you have the veins, the capacitance system.
Yeah, they're thin-walled, they're stretchy, they can hold huge volumes of blood at low pressure. They basically determine how much blood gets returned to the heart to begin with, the preload.
So when pressure drops, the body has this powerful reflexive defense mechanism, the renin-angiotensin-aldosterone system, the RAA system.
The body's ultimate conservation cascade. It all starts when low blood flow hits the kidneys. They sense it, and they release renin.
Which then gets converted into angiotensin II, mostly in the lungs.
And angiotensin II is an incredibly powerful weapon. First, it causes severe, immediate vasoconstriction that instantly raises blood pressure. What's fascinating here, though, is that it also stimulates the release of aldosterone and ADH.
Which tells the kidneys to hold on to sodium and water.
Exactly. You increase your blood volume, which increases your preload, which further raises your blood pressure. It's this whole process that's constantly working in the background to maintain perfusion to your organs.
And that matters because basically every major hypertension drug we study is designed to interrupt one of those steps, whether it's blocking renin or blocking angiotensin II or blocking aldosterone.
But the RAA system is dangerous if it just runs unchecked. So the body has a counterbalance, the natriuretic peptides, ANP and BNP. They're released from the heart and brain in response to high filling pressures.
So during fluid overload or heart failure.
That's when you see them. And their action is the complete anti-RA. They promote diuretic effects, they make you excrete sodium, and they lower blood pressure. They're trying to relieve that fluid strain on the heart.
And the source material notes they get broken down by an enzyme called neprilysin, which, links them to some cutting-edge drug targets designed to stop them from being broken down.
Right. And finally, let's look at the fluid balance at the tiniest level. At the capillaries, the capillary fluid shift. At the arterial end of a capillary, you have hydrostatic pressure. It pushes fluid out to deliver oxygen and nutrients.
Then, at the venous end, you have oncotic pressure. That's the pulling pressure from proteins in the blood. It pulls the fluid back in to collect waste products. There's a balance. But here's the clinical, so what? Heart failure. When the heart fails, the pressure in the veins rises dramatically. That increases the hydrostatic or pushing pressure at the venous end of the capillary. If that pushing pressure becomes stronger than the pulling pressure.
Fluid gets left behind in the tissues. And that is edema. Whether it pools in the lungs or in your ankles, it's the same mechanism. And that imbalance is a primary target for treatment.
So we've completed the operating manual. The key takeaways for you listening. First, the heart is governed by automaticity. It's its own pacemaker.
Second, always remember, the ECG is electrical, not mechanical.
Yeah.
You absolutely must assess the patient for actual perfusion and cardiac output. The reading is not the pump.
And third, blood pressure and fluid volume are in this tight balance. It's controlled by arterial resistance and these really powerful opposing hormonal systems. You have the RAA cascade trying to conserve volume and raise pressure versus the natriuretic peptides, which are trying to correct an overload.
So what does this all mean for you, the learner? This foundation we just built. It's the map. Any drug you study for rhythm control, for hypertension, for edema, you're really just learning how to adjust one of these specific levers.
You're modifying the S node rate or blocking the RAA response or just adjusting that critical fluid shift balance.
And as a final thought for you to explore on your own, we emphasize that the heart's coronary circulation is an end artery circulation. It has very limited backup, not a lot of collateral circulation. So think about this. Given how robust the heart is, it's its own power plant, it's highly resistant to nervous system failure, why is the muscle itself so structurally vulnerable to just a single small blockage in its blood supply? What evolutionary trade-off makes this pump so incredibly durable electrically, yet so fragile structurally when it comes to getting its own oxygen? That's your deep dive homework.